Good morning, everyone, and thank you for being part of this effort to end chronic homelessness in Los Angeles. I absolutely believe that we will do it. I think that the report that we've heard and I was looking at last night and this morning shows real progress. And the way I think about sort of how you gauge these things is that these kind of projects fit the snowball model, right? That you develop momentum, you imagine that the snowball is going down the mountain, and as it goes down the mountain, it begins to pick up more and more energy, more and more force, more and more matter from that mountain, and that's really what this effort is all about. And I think that the year to year shows tremendous progress. But what I expect to see is exponentially more progress in the next year, because we're going to keep picking up additional great people, additional great projects. We're going to figure out new ways of doing this. And so I'm incredibly excited. I want to take a moment and say that just as someone who's still relatively new, I'm coming on 3 years, so maybe that's not so new, but I'm amazed at the phenomenal people in Los Angeles working on this issue at both the county level, the city level, philanthropy. Hilton Foundation, Bill, Ed has been a great partner, and we really appreciate the support you've given us to the health department around homeless projects and providing more housing. And we've had great partnerships with multiple people in this room, and I really applaud all of you for being part of this. What I'd like to use my time is to think out loud with you about some of the ways we can make this dream come true, some of the ways, some of the available leverage points that we have. Remember that part of why, and something I think it's important to understand, homelessness really can be solved. And I say that as a primary care doctor who all the time sees people with problems that cannot be solved or that are exceedingly hard to solve. Lung cancer. Really, you have the best resources, really hard to survive lung cancer, especially past a certain stage. Substance use. Very, very hard. Not to say that people cannot do it, people can, but many of you probably know people with really complicated substance abuse addictions who've gone through the best treatments possible and who remain addicted, whose lives, their family lives have been destroyed. Homelessness is actually solvable. I mean, we have met, all of us on our paths, we have occasionally met the chronically homeless person who, despite multiple attempts, we cannot keep them in housing. But those are really rare. Almost always we have been able, even with the people felt were the hardest possible, if you, instead of saying, we're going to put you here, you said, what is it that you actually want in order to stay housed? It has been almost always possible. So here, unlike sort of lung cancer and substance treatment and other diseases that you can think of, right, here we have a problem that we actually can solve. The other thing I think is very interesting, if you're sort of on a paradigm, is this solution is not more expensive than the non-solution, which is another reason you should believe that we should be able to do this, right? Because while things like sequestration do pose problems, right? Because they cut off a particular funding stream that we need and have used. But it would still be true to say that not housing people does not save us money, right? We're not busy accumulating huge amounts of money at the city level or the county level. Oh, look, yes, we have all of these people living on Skid Row, but look at all the money we've saved. No, we haven't saved any money. And the converse is also true, that were we to successfully house all of the chronically ill people, our sum total of expenditures, and this has been well proven by studies done by the Corporation for Supportive Housing and others, would certainly be no more than we're spending. And depending upon how you targeted, perhaps less than you're spending. So we have a problem that is inherently solvable. We all know that, right? We've all actually seen. Okay, sorry, I'm in the wrong spot. No, it's a common problem I have. Okay, so we've all seen people be housed, and we know that it is in fact possible that it's done. And we can agree as a community that even if we're not exactly sure how to align all of the pieces, and that it's not necessarily easy to align all the funding pieces, in the universe, it would not cost us more. So, that's a pretty good setup for problem solving. I ask you to do the same thing about heroin addiction. Really hard. Really hard. Even harder, try to think of speed addiction. Right? Try to think you really want to tackle speed addiction, which destroys, huge numbers of people. Try to do the model of, we have the treatment that works and it wouldn't cost us any more. Doesn't work on either parameter. It's part of the tragedy of speed usage, right? But here, we could do it. So what are the pieces to work on? Well, clearly, in the next year, and we're working on it hard in health, is to try to use the health reform legislation as another major jump in our efforts to house the chronically ill. It helps us in a number of important ways. One way it helps us is that in the past, we've seen our road as qualifying people for Medicaid. And we know that many of the people who are chronically homeless really do qualify for Medicaid. However, qualifying them has in and of itself been an obstacle. Unnecessary, I would add, but an obstacle. And so one of the things that the health reform legislation enables us to do is to be able to immediately be able to qualify people who are low income, right, for health services. Now, we have a problem that Carol and I have been talking about and that we are going to solve, although it's because it involves the federal government, it's probably not a 2014 solution, it's a 2015 solution, but not too soon to begin to work on, both on an advocacy level and a practical level. The problem we have is I would ideally like to use the money that people get for health benefits to at least partially offset the cost of housing them, which is something, again, from the money point of view, it works very well. Because if I were to take people who are, say, our largest hospital, LAC-USC, who are chronically homeless, and I were to identify those people who have been there the most times and have the most complicated medical illnesses, and I were to house them, I would then save on the medical costs. And so my economic model works just fine. The problem we have at the moment, which again is not going to keep us from doing it, but it's something that we'll have to work on to really bring this to scale, is at the moment the housing expense cannot be recognized as a health expense. And so what happens is that when the state and federal government determine what my expenses are for caring for low-income people, in order to determine what is the appropriate actuarial rate to pay us, because the government, understandably, they don't want to pay us or any other healthcare provider more than it costs to provide their healthcare, and that's fine, right? We're not profit-making, we're not trying, the idea is that the federal government, often through the state, will pay under Medicaid what it costs the health system like ours to care for people. Not more than that, but what it costs to care for people. But under the auditing rules, the person's rent can't count. Now the person's case manager can count. So you can, and we've had a lot of success in doing this, figuring out, okay, how do we maximize our Medicaid revenue in order to leverage more money into the system. But at the moment, the actual housing cannot count. But that's changeable. And Carol always helps me when I come up with really hard problems. Carol, is there any other way besides the 1115 waiver to fix this? And she says, nope. Multiple people have said, I got one vehicle, the 1115 waiver, and it will be negotiated in 2014. And other states have achieved this. And so I think the more data we can put together in the next year or two to be able to demonstrate that this model works in real time, and we will not, right, this is not a handout, right, this is not saying, because any time, not that I would be, against the federal or state government giving us large amounts of money to house people, I'd be in favor of that, but then you're on the long line of people who need additional money for additional good deeds, and much harder to get. I don't want to be on that line. I want to be on the line saying it's not going to cost you a nickel more, right? And here's the data, but I need you to waive this particular rule. I think that that's going to happen. Beyond that, we've been working hard with Marv from the Department of Mental Health, as well as John Fielding in Public Health, because some of the other opportunities to leverage what we're doing are that both the Medicaid expansion and the equity legislation require expanded mental health and substance treatment benefits. Now, while I was saying substance treatment, for example, very hard problem, very hard to end the way I know how you end homelessness. That doesn't mean that it doesn't make a huge difference to treat people. It does. And so being able to have a variety of treatments, and there are some now markedly better medical treatments for alcoholism than we've had for a long time, much easier for opiate use than methadone now. The Suboxone is much easier to administer, much easier to enable people to have normal lives where they're not starting every day at 7 a.m. at the methadone clinic, so that these services are now, going to be paid for. I think it's also relevant for part of our effort, remember, is that how we're going to end chronic homelessness is we're also going to prevent the development of homelessness. And I think here, too, there's a tremendous opportunity because many of the people who are chronically homeless and are impaired at a very significant level, 20 years ago, there may have been a way to keep them from that point, right? Not so relevant now, but there are other ways in terms of, brief interventions around mental illness, chances. For example, one of the major breakthroughs that I think is very relevant to our prevention work is the understanding that psychosis is itself toxic to the brain. Right, so not so relevant when you're dealing with somebody who's already in their 40s and have lived with 20 years of psychosis, on medicines, off medicines, right? But very relevant to the care of, the low-income person, 18, 19, 22, 24, who starts to exhibit signs of serious mental illness. There's good data to say that it makes a big difference that you start treatment early on because the psychosis itself propels the psychosis. So if you can, quickly identify, right, which is often the first part, right, is this, just, an adolescent, right, risk-taking, is this, it gets often confused because often people who are exhibiting new signs of mental illness will also use substances, and so people think that it's all the substances, so they don't diagnose the underlying mental illness, right, and so it doesn't get treated. But I think we have an opportunity to really make a difference. And so, let me close, as others have talked about, the big thing that I think LA, from what I understand, if you will, I've only seen the good years, but I've now heard stories about some of the older years. And I think that, LA, just because of its size, right, it's a challenging place to get stuff done. On the other hand, because of its resources, including, people like you, stuff can get done with amazing speed and ability. So the question is, can we, get the city and the county working together? Can we get the different funders working together? And the answer that I see is, yeah, people are aligned. People, are telling me when I've gone to different meetings with different housing authorities and different city leaders and I keep hearing the same thing. Yeah, we want to end chronic homelessness and we're prepared to do our part. I have not heard, people blaming one another, which I understand has been, maybe it was perhaps part of the old history. Who cares, right? That's not where we are now. We are in a place where people are ready to work together. And so, for that reason, and because we have the common knowledge that homelessness, chronic homelessness really can be solved, we really have that ability, I feel tremendously hopeful. Thank you all for participating and making this happen.
Thank you, Mitch. I want to open it up to comments and questions for Mitch or other comments you might have from the morning. But before, I'd like to ask a question. So, last year when you were with us, you kind of challenged us. I mean, often we talked about projects in the morning. Manuel Pastor talked about doing projects, and that there's a tendency to often kind of do good projects, show evidence. That's great. I remember last year, he said what nobody wanted to say. We need 15,000 supportive housing units, and it's almost an anathema to kind of dream big sometimes. We've heard this morning, it looks like we still need 10 to 11,000. Not to mention maybe people that would be coming in. So that issue of scale, and that's what also Manuel Pastor this morning talked about, successful social movements, moving to scale, and he talked about pragmatic approaches to scale as well, which is something I've been impressed with, the approach of your department. So I wonder if you could just say something about, how do we get to scale? What have you learned over the last year, and what are your hopes for really getting to scale?
I very much, I believe that the 15,000 that I talked about last year may be less than we can do. It's certainly, we are going to achieve that 15,000. I don't have any doubts, and just looking at the data from this morning, I think we did our year's work toward that 15,000. But I mean, in consistent with the snowball analogy, that doesn't mean that I expect that each year the amount of progress we made in the last year, that we're going to make only that much progress. Well, I think that we have the opportunity now, and the collaborators and the alignment, that you will see that next year our progress toward that 15,000 will be bigger than it was in the last year. So we're going to do that.
Great, thanks. All right, let's open it up and hear from you. Again, questions, could be comments from anything we've heard this morning. Who wants to? Lindsay.
You referenced definitely that permanent supportive housing is a long-term way to at least equally spend the same amount of resources. What have been your successes in working with the nonprofit hospitals or other folks in the healthcare system who are also struggling with high-frequency users, and how are you planning on getting them on board with the shared vision of moving this path of health driving the way to prevent homelessness and the solution to ending homelessness?
So first, I don't know, does everyone know Lindsay Angelis, who is from San Francisco, and I think a very welcome addition onto Mary at UniHealth. And so I think that Lindsay joining us is in and of itself a good and positive sign. The hospitals and the health systems are really anxious to work with us. The various changes in the healthcare system from the pure fee-for-service into some form of bundled payments. While it's not happening, overnight, and there's still a lot of fee-for-service, everybody, supports the direction of going to bundled payments. Let me take a step back for those of you who don't live in the health financing world. Most of American medicine has been based on the principle of fee-for-service. You do something, you get paid. And that fee-for-service mentality often means that if you're a homeless person and you have Medicaid, and you go multiple times into the hospital, get multiple CT scans and multiple workups for infection, hospital does just fine. Not a problem, right? In fact, some things like, radiology equipment, although it's horrible to say, and they don't mean it, you've got to run your hospitals. More volume is good, right? You got the machine, right? You got the tech, you got to have it. So if you can do more CT scans, you make your hospital run better. That's just the nature of how hospitals are financed under fee-for-service systems. Now you move to say, no, it's not good, and it's not good. Fee-for-service is not good because it results in people getting tests that they don't need, right? It puts the incentives in the wrong place. So the movement in our field is towards saying either there is a payment for a particular illness, like X amount for a hospitalization for pneumonia or a hip replacement. Or there is even better, you're going to get paid as a system $300 a month, keep the person healthy, and you still get your $300 a month. If they wind up in the hospital, right, you're going to have to pay out more than $300 a month. So that's what then fuels the interest. Mark has told me, and I don't know, maybe I'll pass it to him, to talk a little bit about his early experience in getting hospitals both to understand what the opportunity is and to be interested in the kinds of programs that we're doing. Do you want to? Is that a fair question, Mark? I'll put him on the spot. He'll introduce himself.
Hi, I'm Mark
already know
Trotz, working for Mitch. Been here for about a year and have been working with many of you, so it's great to see you. I mean, I think, to date, it has been the public hospitals that are most interested in it, but certainly the other hospital systems are seeing what we're doing and what we're pioneering in various public systems, and I think with healthcare reform, they're starting to see what we've been telling them. I think in the last 10 years, it's been hard to get traction because they just haven't had that. The incentives haven't been aligned, and suddenly people are coming back. Health systems, health groups are coming back and saying, "Well, what is this supportive housing, and how can this help this person now that we're responsible for?" So I think it's going to really accelerate, and I think we're really excited about healthcare reform and the way, these incentives are realigning. So we'll take that challenge to get to the 15,000, and that's on all of us.
Great. Thanks, Mark. Manuel had a screenshot of a report that came out a week or two before the Economic Roundtable. Dan Flaming's here, and that several funders, Hilton, UniHealth, have supported the work that CSH is doing on frequent users. And so they've been working with a number of hospitals throughout the county as well. So in addition to the county, yes. More questions, comments? Mike, again.
Given that we already know we have a shortage of permanent supportive housing, are there ways that we can expand the number of respite or recuperative care beds in the county, given that there's a relatively small number in the county, and obviously hospitals, I think, could be incentivized by Mark's comments that we just heard to participate in the system, and it seems like that respite care might be an important part of that. Do you have any ideas on how we might expand that capacity?
Thanks. So we are going to expand respite in the next year. Again, let's take a step back for everyone. and talk about where respite falls, right? So as a group, right, our goal is permanent housing. Our goal is not respite. On the other hand, it is not always easy or practical to go directly from somebody who's in, a hospital at $3,000 a day cost, receiving 24-hour nursing and a variety of other services to they're in their own unit, right? There are sort of ramping down issues about levels of care, right? There are issues about signing leases and getting benefits in place. And so we view respite as a, very good ramp. It's, or a launch pad, maybe is the more positive thing, especially since we're at the Space Museum, is that what we want respite to be is the place that you go from the hospital to get everything ready so that you can go to housing. I think what's important to understand is that what we cannot have is very long respite stays. That will blow out our dream, right? Because once the problem with respite is that it is generally not a reimbursable expense at the current time, and it is not inexpensive, right? It's less than a hospitalization, but depending upon what you're actually providing, you may be spending, say $100 a day, $130 a day. Now, to a hospital administrator, that sounds like nothing, right? Because a hospital day is $3,000. But the hospital day, remember, in my current system, I can get reimbursed for. Now I'm going to $130 a day, which I'm not going to get reimbursed for at all. And again, as a day against the hospital, that sounds great. 130 times 30 does not sound so great to me, right, compared to supportive housing. So the trick is, what you want is that it really is a launching pad and that you don't get people stuck. And one of the things that Mark and I and the other Mark who works with me on this, Mark Galley, and I discovered is we had some people who were in respite for very, very long periods of time because there wasn't any supportive housing, right? And so you can see you've created now the same problem, you've just moved it down one notch. So you're still stuck not solving the problem. And so what we're looking at is more capacity, but keeping the hospitalizations short. And recognizing also, and this is something that not always appreciated by people, some of our clients / patients do better in less restrictive settings. And so I'm always, Mark and I talk about this a lot. I don't like settings that have too many rules because some of them really, it just worsens their behavior and creates situations where you can't actually serve them in a patient-centered way. And so trying to figure out what is the right place for everyone is key to our solving this.
Thanks. Time for one more question, please. Or comment?
Can I just add to the respite care issue? We fund respite care as a healthcare issue, and with the changes in payment methodologies, hospitals are incented to cooperate in respite care projects. So the cost is the startup. You have to fully fund the operations of, say, a 30-bed respite care unit, whether or not you have 30 people in it. Hospitals are willing to pay for respite care because of the readmissions penalties, because of bundled payments, because of value-based purchasing. The hang-up is getting them out of respite care into permanent supportive housing that may take 4 to 6 months. So we've got a big project we just funded, for example, in Pomona, where part of the model is transitional housing. So you need to have some place between respite care and permanent supportive housing where they can go and live safely, because if you discharge them from respite care, you lose them and you find them again in the emergency room.
That's right.
So developing these projects that are partnerships among hospitals, respite care providers, social service providers. In the case of Pomona, it's the YWCA, permanent supportive housing providers, FQHCs to establish medical homes. Takes a little doing, and in the Pomona case, we have philanthropic partners like the Weingart Foundation, but we need that essential piece that nobody seems to have, which is that transitional housing piece. And so I just offered that as part of a broader strategy to think about. It's relevant to the work of this collaborative.
That's good, Mary, and thank you for all the work you do at UniHealth in supporting so many of these projects. I'll broaden your comment and say that also is often true about residential substance use programs. One of the things that breaks my heart is you take somebody with a serious substance use issue, you put them in a residential program, which can cost easily $200-300 a day for 60 days, and you have success. And then you discharge them to the street. Guess what happens? Right. They go back to using, right? Because you haven't transitioned them to anything. And then what about that expense in the previous 60 days? What'd you get out of that? Right. And the answer is nothing. Right. Because you spent the money, but you haven't transitioned them. And so I think all of these cases, right, it's always about, when we establish a line of service, what's the exit? What's the entrance? What's the exit? And is everybody spending the right time at the right level so that we have enough money to service everyone? And if we get everybody at the right level for the right time, we do. So thank you so much, Bill,
Thanks.
for inviting me.
Thank you.